There's lots of BTK inhibitors under development, but the good news is each class is looking maybe a little bit more promising than the last. So right now, I think the current standard of care is a covalent BTK inhibitor, and when that progresses, you can do a non-covalent BTK inhibitor, and when that progresses, potentially these BTK degraders, again, those are only available on a clinical trial. But all of these drugs are going to move up, and the question is going to become, is it better to give your best drug first? And so there are ongoing trials trying to tease that out to understand, is a non-covalent going to lead to better outcomes than a covalent? And one day, I'm sure we'll see trials with degraders. For the time being, I think having all of these are great because they work after each other. And so for patients, it means that they can go from one oral therapy to another oral therapy to another oral therapy. And the good news is as we talked about the Nurix clinical trial and pirtobrutinib, and additionally, these have been generally the newer generation drugs are not only efficacious, but very well tolerated. And so how that plays out, we'll see as trials mature over the next 5 to 10 years. But for the time being, I think we have lots of good options. And for patients, I think it serves an important clinical need.